Ladies and gentlemen, we now proceed to the last symposium for the day on multiple sclerosis across the clinical spectrum. This will be chaired by Dr. M.T.M. Rifsi and Dr. Danushka Vithanavasam. Over to you.
The next symposium has three experts are speaking on three important topics regarding multiple sclerosis. The symposium is on multiple sclerosis across the clinical spectrum. My co-chair, Dr. Vithanavasam, will introduce the first lecturer.
Thank you very much, sir. It's my great pleasure to introduce Professor Andrew Chan, who is a renowned neurologist and internationally recognized expert in neuroimmunology with a focus on multiple sclerosis and related autoimmune disorders. At Bern, Professor Chan serves as a full professor for ambulatory neurology, neuroimmunology, and multiple sclerosis. And he is actively involved in many professional societies, including many leadership roles in Swiss Multiple Sclerosis Society, German Multiple Sclerosis Society, and ECTRIMS. So let me invite Professor Chan to commence his presentation.
Afternoon. It's in fact morning here in Europe. Thank you very much for the very kind introduction and also for the honorable invitation. Unfortunately, I was not able to attend your meeting in person, but I'm certainly eager to get to know your beautiful country and the people on one of the next occasions. So here are my disclosures. I hope it advances. So I was not really happy about the title of my talk, although I chose it myself. But really what I try to convey here is where we are currently with, it feels like we go 2 steps forward and then 1 step backward in terms of scientific progress, especially when it also comes to treatment. And so although I know that Hans-Peter Hartung has alluded to the BTKIs earlier this morning, I will also lose some words about BTKIs. But also I want to particularly highlight really caveats and common mistakes maybe that we're making or that we have to make. And with this, I really want to also address in this symposium on phenotypes 2 specific aspects that we have only more recently embarked upon and where we're only currently trying to move scientifically. And I want to show you some preliminary data on functional neurological disorders and especially also fatigue. So BTKIs are a big thing currently. So we're talking about roughly $10 billion in 2024 on market value, and estimated are roughly $30 billion in 2032. So this is really a major issue for the pharmaceutical company. But as somehow enthusiastic we were last year with the different clinical trials, especially the non-relapsing secondary progressive MS trial with tolebrutinib, which really in this cohort did show a quite robust efficacy on disease progression. Somehow there was a backlash in that late December, 15th of December, the sponsor indicated that the PPMS trial was negative. And really on Christmas, FDA also indicated that at the current stage, it cannot approve the application for non-relapsing secondary progressive MS of tolebrutinib. As is normal, there's a complete response letter to the sponsor. And I think it's worthwhile to have a look into the reasons the FDA gives why they cannot currently accept that application. So they, of course, highlight the benefit-risk profile, indicating that if you in the pre-marketing setting already do see drug-induced liver injury, then the risk of post-marketing cases is, of course, higher. But I think what is even more important are their reservations on the disease subpopulations, because they rightfully indicate that there were 13% at baseline of the non-relapsing SPMS population, which indeed still have cranial disease MRI activity. They interestingly also somehow critically discuss the concept of PIRA in itself, which I find interesting, if I put it that way. In essence, they, in their analysis, were not able to indicate a subpopulation which was specifically benefiting from that agent. So the story is not over. The FDA invites the sponsor for additional analysis, especially on the risk and risk mitigation of drug-induced liver injury. So what are we talking about? If you look at the trial data on liver safety in that non-relapsing SPMS trial, at the first glance, it doesn't look too difficult. So when you look at ALT elevations, yes, there's an ALT elevation, but it's not to a major extent. However, I think the real message on this slide is on the right-hand side, especially when it comes to higher degrees of transaminase elevation, and when it comes to the right-hand bars, where really cases of Hy's law are indicated. And Hy's law is something we have seen so far relatively rarely in MS clinical trials. Why is FDA so vigilant about that? Hy's law is a combination of ALT and AST above 3 times upper limit of normal in combination with bilirubin 2 times upper limit of normal, with the exclusion of other causes. If you have that biochemical signal, then statistically there's a risk of 10% clinical liver failure with mortality or also transplantation. So in other words, FDA reckons if you have in the pre-marketing setting already single cases of Hy's law, and as you know, in the clinical program, there was one transplantation which also led to death, unfortunately. Then when you increase the exposure to the post-marketing setting, of course, these numbers will increase. Now, Hans-Peter Hartung has alluded to different BTKIs, and I think the situation is really difficult to understand. So evobrutinib and tolebrutinib did not show any effect on relapse-associated outcomes, whereas at least according to press release, fenebrutinib did. And there are other inconsistencies, which may be because really we do have different BTKIs, which differ chemically from the molecular weight, but also, for example, with CNS exposure. But this may not be the only explanation. There may be very, very simple and very, how can I say, somehow also weird reasons why we see currently so different and sometimes also confusing results when it comes to clinical outcomes in the study program. So one aspect may be a simple one. The negative evobrutinib trial was conducted between 2020 and 2023. So this was really at the peak of COVID-19 and when the Ukraine war started. And when you look at these figures, roughly 40% came from countries which were involved in that conflict between Russia and Ukraine. And we also see a high discontinuation rate. And then you look at a subgroup analysis according to different geographical regions, you can easily see that when you look at confirmed disability progression, that the proportion is relatively low in Eastern Europe compared to the other regions of the world, and B, unlike other regions in the world, Western Europe and North America, you just don't see a difference in these regions. So what I'm trying to indicate is that, yes, indeed, our current clinical trials may have been contaminated, at least to a certain extent, by the global situation. And that accounts for all the clinical trials we're talking about. Another aspect may be very, very simple as well. So when we talk about primary endpoints, especially in progressive trials, we're of course talking about whatever composite with EDSS. And here the question arises, how about EDSS, especially in elderly cohorts, so roughly 50 and older? And there's a quite old paper, which I still find quite sobering, I have to say, because if you compare a population, an aging population, here in orange, and non-MS population, and in blue, an MS population, you can see that someone, an otherwise healthy person without MS, already formally at the age of roughly 55 or so, has an EDSS of 2 and above. And even without any MS, the formal EDSS will increase over time because, and that's logical, we all will experience comorbidities, which of course do contaminate our EDSS. So what I'm trying to indicate in here is that really our gold standard EDSS in our clinical trials, even in a composite fashion, may, which is not perfect anyhow, may even be more complicated in the elderly when we really try to differentiate effects on treatment on MS from aging or frailty or comorbidities. Let me slowly switch gears and go away from the BTKIs, but still go to phenotypes, which is the clinical, which is the topic of our symposium. And let me come to a clinical phenotype, which we all know, but which really may have implications which probably we only starting to understand. So these are two exemplary patients which were referred to us as non-responders under anti-CD20, and maybe they were eligible. The colleagues thought for a CAR T-cell treatment trial. So the first patient is a male with an MS and an polyarthritis who has increasing motor dysfunction and also fatigue, despite the MRI being stable and despite a combination therapy of anti-CD20 with methotrexate. And the second patient is a female, also with spondyloarthritis, with spasticity and ataxia episodic, reported as relapses despite a combination with anti-IL-17. And when you look at the simple old clinical examination, you see a left facial hypalgesia with a midline split, including the angle of the mandible, but also when it comes to motor signs, a positive Hoover sign on the left leg. And likewise, the female patient had different indicators really suggestive of functional neurological disorder, positive signs suggestive of functional neurological disorder. So let me just indicate what is that, what are positive signs, what is the Hoover sign. So a functional disorder is when a patient really experiences an abnormal function, but the hardware, so to say, is really capable of normal function. And a positive sign, such as the Hoover sign, would be this one. So the patient is being asked to raise or move at all the right leg. The examiner passively raises the right leg, but nothing happens, and the leg will fall down to the underground. But when the patient is asked to raise the left leg, there will be an antagonistic co-contraction, which is so strong that the examiner is able to lift even the whole hip. So clearly, the right leg, the motor function in the right leg is possible, but there's an incongruence. So, and that's really the basic idea which underpins all the positive signs of functional disorder. What is that? What are the official pillars of diagnosis? It would be inconsistency over time and distractibility, and also incongruity. So clearly we are breaking anatomical or physiological rules. For example, also with the facial midline splitting that I indicated for sensory dysfunction, which of course is not strictly midline, following a midline boundary. What can we say about FND, functional non-neurological disorder? It's very common in general neurological outpatient clinic, and we all have patients in mind that we do remember. The FNDs do have a fluctuating, a multifocal, and a paroxysmal nature. So it's clear we will have an overlap with MS, and we of course know these patients. And really, using different criteria of functional neurological disorders, you can quantify a overlap to an increasing degree, and there are studies even with up to 40% with such an overlap. One more recent study is from Italy, where of around 300 consecutive patients, around 6% did have signs indicative of an FND. So this number per se is not the issue, but really the other implications. So A, there's a higher rate of mood disorders in these patients, which somehow makes sense. But B, for the management, there are different issues. So there's a higher rate of therapeutic switches due to drug intolerance. So these patients with functional neurological signs would not tolerate the treatment properly. And the EDSS is falsely high, even up to 1 point higher than when assessed by I would say, a non-FND expert in comparison to an FND expert. So we really have also a contaminated EDSS. So what are the implications? And this is really where we are right now. So we do have a similar epidemiology with female preponderance and age between FNDs and multiple sclerosis. We know that the relapsing phenotype predisposes for FND, maybe because people with MS remain in a high state of alert. They just don't know what happens next. The MS may be a trigger with a reduced sense of agency, and I will allude to that in the next slide, leading us to the hypothesis that there could be a similar pathophysiological mechanism. So we know that there are predisposing factors for FND. Noteworthy, really, psychiatric or psychological vulnerability, stress or childhood abuse, sexual abuse or something is not mandatory. There can be patients without obvious psychological vulnerability. However, our MS patients are clearly predisposed for FND because they do have brain injury. So this is a precipitating factor with a clear comorbidity. And yes, they also face perpetuating factors. This is something that I have mentioned before, diagnostic and prognostic uncertainty. And this reduced sense of urgency, agency, is certainly something that we can clearly understand neurophysiologically, because there may be a network dysfunction where you have an impaired integration of bottom-up sensory input, which is clearly the case in MS, which leads to a mismatch with top-down predictions, motor predictions, and sensory predictions, which may then lead to functional neurological disorders. This is really what we're having right now. What are the implications? So in these patients, we have more therapy switches, so we expose them to a higher risk. Often we may have a presentation which may be mistaken for relapses. The EDSS, as I mentioned, is not reliable, but also the adherence and the drug tolerance may be an issue. However, we just don't know how big the problem is. Let me end with the last phenotype, a conundrum really. Fatigue, a subjective symptom without any unanimous definition. leading to unclear focus on pathomechanisms and the lack of specific treatments. Why is that? Because really there are so different dimensions of fatigue. It's really the assessment, it's different concepts over time, the psychological domain, the different domains at all. So it's really difficult to combine those different aspects, even when it only comes to things like trait and state fatigue. Also, what we're lacking is a concept of fatigue over time. Even if we look at evidence-based triggers or factors that influence fatigue, such as genetic predisposition, immunological factors, functional, structural aspects, and behavioral dysfunction, it is probably quite evident that these factors will not at all times play the same role, but really may diverge over time with different sort of predominance at different stages. So there may be different sort of windows of opportunity for different therapeutic concepts. And it's clear that we can only tackle that conundrum with certain novel readouts, maybe ideally in a multi-center approach, ideally even with cohorts of similar cultural backgrounds. This is something we tried in our neurotech loft. At Bern, we do have an apartment which is video and sensor equipped, so everything is really you sleep there, you take a bath there, you cook there and work there, but we can track everything. And we can also understand where you're moving, how often you're moving, how fast you're moving. And this is really the first case series where we have patients with low fatigue, high fatigue, and intermediate fatigue. And what we see with simple measures as that this gait velocity and the stride length may be different between these phenotypes, and that those patients with high fatigue may have a decrease of really a fatiguing in step length and gait velocity. This is, of course, only some pilot data, but this is something we're following up. Therapeutically, we probably need to focus on different approaches, maybe something like that. Coming from a more molecular side, this is really new to me, but fortunately we do have Iris Katharina Penna with us now, a leading neuropsychologist, and she's really pushing forward these concepts. Maybe we have, with metacognitive training and mindful-based meditation, a better approach to understand the disease for the patients and a better coping. And this is something she's following up in a prospective trial, also with digital readouts. It's a binational trial, which we're doing together with Vienna. They speak German. They have a similar cultural background. And these are the first sort of pilot data after 50 patients. So the primary endpoint would be cognitive dysfunction, patient-reported, and with the SDMT objectified. And yes, clearly we do see an effect, but also when we look at fatigue. So coming to an end, I hope I could indicate to you that BTKIs are really a pearl, but also we do have pitfalls there. The evaluation is still ongoing, but I really hope that 2 steps forward and 1 step backwards is still netto 1 step forward. We do have functional neurological disorders. We don't know how big the problem is. For fatigue, neuropsychological dysfunction, certainly we need to have new approaches, and FND clinical clues are still important. Thank you very much for your attention.
Thank you very much for that insightful talk, Professor Chan. And now I believe Professor Chan would be happy to take a couple of questions from the audience. I would like to ask a question, if I may, Professor Chan. You mentioned about these functional neurological disorders in MS patients, which is very interesting. So in epilepsy patients, we know that non-epileptic attacks are very common, maybe common than the normal population. So similarly, do you think that functional disorders are more common among multiple sclerosis patients, or do we have any figures about that?
So yes, there are data from the UK which indicate that FND is really among the different neurological subspecialties approximately equivalent. So you see them in all outpatient clinics, be it neuromuscular, be it whatever, headache even also, to a similar extent. However, I believe epilepsy and movement disorders, I think this is where the phenotypes are so extreme sometimes that the attention may be much higher there.
Thank you very much.
Hi, Andrew. Owen Flanagan here. How are you?
Hi, Owen.
How's it
Good.
going?
Good to see you.
I was just I was very interested in your functional neurologic disorder story, and I think it's something we definitely see a lot in our clinics. You know, with the era of many different biomarkers and people sometimes anchoring on antibody results like TPO antibodies or other antibodies that have very low specificity that can lead to a diagnosis of Hashimoto's encephalopathy. I think we're seeing this more and more. Do you think we need to focus better on education of our neurologists as they go through their training? If I think back to my neurological training, there was very little focus on functional neurologic disorder compared to how much we see in practice. So I'm wondering, is there a way that we could improve that? Because people tend to sometimes focus now more on test results rather than examining patients and really delving into detail to figure out the diagnosis.
Yeah, thank you very much, Owen, for this very important question. So number one, I'm really grateful that you as an antibody guy really also highlight the value of clinical examination. I mean, this is really back to the roots, right? I sometimes feel like a dinosaur when I still touch the patient, but it's sometimes really helpful. And yes, we need to teach our residents. A, they need to understand the concept, and B, also we need to teach the other colleagues, non-neurologists. This is not a psychosomatic something. It's really we do have clear mechanisms there, and this is certainly just like a different phenotype of a disease. So the stigma needs to be removed. And yes, we need to do some teaching. We're currently trying, having a trial also together again with Vienna, where we do exactly this. So we have a EDSS expert and an FND expert on motor symptoms, and they do the neurological examination and the typical EDSS. And prediction is of course clear that the EDSS is not appropriate in these kinds of patients. And once we do have these data, I think that the case is much easier even to expand education.
Thank you. And let me introduce the next speaker. She is Professor Ellen Mowry from Department of Neurology and Epidemiology, Johns Hopkins University. And her main interest as a clinician, scientist specializing in neuroimmunology and multiple sclerosis. And she will be speaking to you on extremes of MS, aggressive versus benign. It's over to you, Prof. Ellen.
Good afternoon, everyone, and thank you so much for inviting me to give this talk. I really appreciate the invitation from the organizing committee. And this isn't exactly in my area of research, but it was a pretty interesting talk to put together. So here are my disclosures. I thought first maybe I'd provide some history about the concept of benign multiple sclerosis in our field. Also to review some cases with you to see if you think that they are benign or aggressive. And then to think about how must we define benign versus aggressive? Should we continue to use the definitions as they were set up? or are there other constructs? And then I'll wrap up with discussing the pros and cons of studying extreme phenotypes. So the literature is replete with lots of examples of what I think we would consider the most benign phenotype of multiple sclerosis, which is the notion that some people die and at autopsy have evidence of multiple sclerosis in their nervous system and had never complained of neurologic symptoms. And so when I was in training, this was certainly something that was brought up, and it's something we even discussed with patients when they worried about how severe their MS course might get. We would say, there are people who on one extreme have no symptoms. And so, we kind of use that as a good way of strategizing to say that not everything is going to be bad over time. And I liked this little quote from the paper. This is an old paper saying it's still based on symptoms. Of course, I had the opportunity to work with Professor Darren Akuda when I was in training, who, of course, has gone on with Christine Lebrun and others, Orhun Axel and others to really characterize what has been called radiologically isolated syndrome, which is when we find evidence of multiple sclerosis on imaging studies and without on the presence of symptoms or signs on neurological exam. And Darren coined this term back when we were working together called radiologically isolated syndrome. And they've done many, many studies of these cohorts over time and show that a good percentage of people who have imaging for incidental things, like they're in a car accident or they have a headache, and lo and behold, they have lesions that look like MS, do eventually develop some symptoms, whether they are relapses or progressive phenomenology. And there is pathologic tissue destruction of the lesions that occur. So I think this has really caused us to rethink whether asymptomatic MS, at least if discovered early in life, really is benign. If you look back at some of the literature on radiologically isolated syndrome, or even on some of those autopsy cases, it seems in retrospect that there were probably some symptoms. Maybe they just weren't attended to by a physician. And of course, the results of 2 of the clinical trials testing MS disease modifying therapies in people with radiologically isolated syndrome further highlight, because they were beneficial for those who received treatments, that perhaps benign is too strong a word to apply to currently asymptomatic or never yet symptomatic multiple sclerosis. And I think these are the considerations that allowed for the recent changes in the MS diagnostic criteria to include at least some people who had not yet had MS symptoms. So what is the history of this notion of benign versus aggressive MS? Well, the early literature was really looking at benign MS based on the scale we just heard about, the expanded disability status scale, over time. So, of course, the expanded disability status scale is really just mapped, as you heard, from the neurologic exam to a 0 to 10 scale. And essentially, the traditional MS literature would say, okay, like if you started off with MS and we've been following you for X number of years, whether it's 5, 10, 15, 20, and you still have an EDSS score less than 2 or 3 or whatever they chose, we'll call that benign MS. So for example, in the cohort on the right, they started with a very large cohort, and you can see that actually most people did not meet the criteria, which they defined as having, the EDSS cut point at 3. So some mild weakness, most likely, or other most likely functional deficits, but not raising up to the level of, getting into trouble walking and things. So most people after 10 years, a very old cohort, no disease modifying therapies, did have some deficits, but they had 200 or so people who met their 10-year definition for benign. And then if you followed them for another 10 years, so 20 years after onset, they did have some loss to follow-up, of course. But of those individuals who they were able to follow, about half of them maintained a relatively mild disease course, but the other half actually had gotten worse. So it really challenges this notion also of like, oh, okay, you're clear if you make it, 10 years and you don't have any findings or deficits. So again, people with benign MS, 5 or 10 years later, you're feeling confident, they can still progress later. When we look at these studies, it's important to remember that when people are lost to follow-up, it's usually not random. And so those might be individuals, for example, who are more disabled. And so you are feeling pretty confident that people are doing well, but in fact, the results were biased by selection, meaning the people who were left to study weren't representative of the whole. We know that many of the long-term prognostic studies trying to evaluate people's long-term disease course weren't really conducted in the era of current disease-modifying therapies for MS. So applying the literature to our current population of individuals with MS can be really challenging. And in the current literature, it can be challenging because we don't know statistically how to best optimize accounting for the disease-modifying therapies that are used. It's also important, and we'll highlight this later, that symptoms that don't contribute to the EDSS themselves can be disabling, and also that the definition of using EDSS by X amount of time doesn't really consider all constructs of severity. So I was thinking about, when would we want to establish that the course could be benign. So we kind of just came over this definition of, if it means disability by X number of years later, we maybe never can tell somebody that they have benign MS. I think it's also really important to think about it from the lens of the person living with MS. So we are really focused on things that we can measure in scales and quantify, like the EDSS, but what's benign to people I talk to when I diagnose them with MS, and what would be a good outcome for them may not be the same thing as our quantitative scale. So for example, when we diagnose people, some people say, am I going to be able to walk forever? So that would align more with the EDSS. Can I walk by the time my child gets married? I want to walk at their wedding. I've had many patients tell me that. Or will I be able to keep working for the whole of my career? So, for different individuals, the meaning of benign or a good outcome may mean different things. And I really want to highlight how the EDSS doesn't capture all symptoms that, although they won't shift the EDSS much, are not benign to people, especially things like fatigue and cognitive changes. It's really hard to move the EDSS with these kind of invisible symptoms, and they can be profoundly disabling for our patients. And indeed, some people who have more symptoms on that side of the spectrum relate that they feel frustrated because they can walk fine, and people can't see that they are disabled, yet they can't function very well. And they feel that people kind of brush them off and say that they seem fine. Why can't they do X, Y, or Z? So, and then thinking about determining benign versus aggressive, when would we like to know that in a person's course? Well, of course, you'd like to know that at the very beginning, right? Maybe that would help you change treatment recommendations. Maybe it would help you think about life planning for these individuals. If you look in the literature, there are so many prognostic factors that have been tested to say, oh, X at the onset or within the first 5 years is linked with disability many years later. And we actually collect these in a clinical trial that we're doing, as you can see in this chart on the right. because these studies that tried to collect these factors are pretty old and often pretty limited in quality, sometimes being sort of univariate or not collecting a lot of them in aggregate. So it's very difficult to tell. And you can just see there are many, many different examples of prognostic factors. So I thought we'd talk through some case examples to see if you think at this beginning of the course for these individuals, we can tell if they're benign or aggressive. So here is the first case. This is a 25-year-old person who presented with imbalance that progressed very rapidly to left foot drop. He underwent a lumbar spine MRI from an outside clinician, and there was a disc herniation in the lumbar spine that was thought to be causal. They tried some epidural steroid, and since that didn't help, he was recommended for discectomy 3 weeks after his initial symptoms. This was sort of caught up in the COVID pandemic, by the way, where there was a sense of urgency to make a decision about surgery because the ORs were thought to be closing down. Unfortunately, post-operatively, he developed marked subacute left-sided weakness and paresthesias with urinary frequency and hesitancy, as well as constipation. And he underwent imaging 4 days post-operatively that showed lesions concerning for MS. In retrospect, he reported, oh gosh, I had these sensory changes in my bilateral lower extremities for a couple of weeks about 6 months ago that I was working and I was busy and these got better. So here is his 4-day post-operative MRI scan, and I can tell you several of the lesions, including one or more of the cervical lesions were enhancing. I was seeing him by video visit because this was about a week into the pandemic hitting in the United States, and he was unable to even supinate his left arm. His fingers were held in flexion. He could not extend them, and he had very severe lower extremity weakness and was walking with a walker. His gait was circumdactory. His strength continued to deteriorate despite very high dose steroids and a prolonged taper that we started him on. We tested him for MOG on AQP4 antibodies, which were negative. A few days later, he began to experience dysarthria and dysphagia, and we elected to start plasma exchange, and the symptoms began to improve. He was definitely still having some motor deficits, but he was getting better. But a week after the plasma exchange stopped, his gait began to deteriorate again. He developed dysarthria, a new left INO, and right lower extremity weakness, so the opposite side. And we re-imaged him, and he had a new lesion in the left middle cerebellar peduncle. The pontine lesion that had been there before was now enhancing. And he had increased edema surrounding and enhancement surrounding the C4 lesion. And so we resumed plasma exchange and started ocrelizumab. And so here's his course. These are the ways we kind of keep track of people's MS course in our clinic. And you can see that the little orange triangles represent relapses. And so he had a relapse that was unknown 6 months before, and then a pretty bad one at the time we met him with back-to-back MRIs demonstrating new lesions. And so, do we think this is benign or aggressive? This is one of the people who kept me up at night for several weeks. So for me, this is one of the more aggressive out of the gate onset individuals that I've had in quite a long time. But what happened after we started the ocrelizumab is you can see there are no more triangles, so no more relapses. And as of last follow-up, also no new lesions on his MRI scan. And you can see below his walking has improved over time. Here's another case. This was a person that when I met was 16 years old. And so this person had also some symptoms that had come to medical attention, but not to that of a neurologist within the past year, some gait changes and stiffness of the legs. and then finally presented with a more fulminant set of symptoms, at which time MRI scan was done that showed pretty substantial burden of MS lesions. And at the time I first saw him, he had nystagmus, he had dysarthria, he had unilateral weakness, dysmetria, and trouble with tandem gait, and an EDSS of 3.5. Despite our encouragement, the person really only would agree to take gluteramine acetate. And so although his beginning course, if you chart it quantitatively, actually kind of looks similar to how the last person kind of relapses in a short period of time, and, some active MRI scans. This person went on to have several more relapses and acquire quite a few new lesions on MRI scan until ultimately did agree to start ocrelizumab, after which things have been quite quiet. This is the original cervical spine MRI for this person. You can see, unfortunately, unlike the last person, this person's gait trajectory has been that of decline. And I actually just saw this person recently, and they have an ADSS of 6.5. And you can see that the most recent spinal cord imaging shows massive atrophy of his spinal cord. So pretty similar onset in terms of frequency of attacks, but it would be hard to say that the course so far is similar for these two individuals. Finally, okay, now another child, pediatric onset MS. First attack was optic neuritis, and then something referable to the cord, and perhaps a third episode in quick succession, and pretty active MRI scans at the time. Again, this was quite a number of years ago, so at that time we recommended first-line therapy for this individual, which is also consistent with their goals. So also looks very similar to the first two individuals in terms of just very hot MS coming out of the gate. You might suspect going for a more aggressive course, but they stayed on gluteramine and remain on that medication and have had no new disease activity over time. So three kind of very active at onset, and you might want to say that these individuals are at risk for disability, all of them, but many, many years out, it's not really clear that they all will. Certainly they have not all developed disability at this time. So when we think about benign versus aggressive MS, we think about these polar extremes along a bell curve. And we want to think a little bit about, what kind of defines the x-axis. So, is it this notion of radiologically isolated syndrome, or MS discovered at pathology, subclinical MS versus clinical? Are we thinking about pediatric onset versus late onset multiple sclerosis? Perhaps we would consider one more or less benign. How much inflammatory activity a person has, relapses, and new lesions during a given time period, and does it matter if they're on or off therapy? How severe the attacks are, or how poorly they recover, could be another set of extremes. If they're early or late progressors, and is that definition based on their age or on how long their disease is occurring? So we all like to kind of categorize things. And so I like to think about what are the pros and cons of doing these kind of categorizations. Why and when is it helpful to split the population of people with MS to create categorizations such as benign versus aggressive, and when is it better to aggregate the patient population? There can be some real benefits, of course, of splitting. So, for example, looking at extreme phenotypes, such as very aggressive MS, however defined, whatever sort of plane you're on, can really help to identify genetic variants and rare environmental factors that might be of interest. And the notion really is that these extreme variants, for example, genetic variants, can explain a larger percentage of the phenotype in that subgroup than they would in the whole. And so you can essentially more efficiently study and look for these sort of rare variants and identify them as relevant to the phenotype. And that's therefore saves money on your studies. I think the other benefit for subgrouping individuals or thinking about subgroups is that discoveries in care, we'd love to kind of come up with a medication that stops MS for everybody, or that stops progression for everybody. But even if we have to chunk it out, right, where we start with the whole and we say, okay, like this extreme, we understand this now, and therefore the treatment is different than for the rest. And then we do it for another group. It still reduces the number of people who continue to suffer from the sequelae of the illness. On the other hand, if you start sort of chunking out the whole population to a very extreme subsets, and then you're trying to study those subsets can be really difficult. They may be too small to find anything meaningful. And then if you do find things, it limits the sort of generalizability of those results. And then I find it just very hard to study across the intersections of potential phenotypes. We looked at those long lists of things that have been linked with worse outcomes, for example, in people with MS. And when you check off those boxes, like we do in our clinical trial, we often find that most people have a mix of things that are, worrisome for a more aggressive versus a more benign course. And as I said before, often the factors aren't measured in aggregate in clinical studies. And so understanding which ones are truly relevant, since so many of them are collinear, they exist together, is important. And then finally, whether factors relevant to prognosis are confounded by indication for use of specific disease-modifying therapies makes it challenging. So I think in conclusion, there's really no single construct that I can think of to define benign versus aggressive MS. There are downsides to using these phenotypes in research, but also some pluses as well. And I think maybe for me as a scientist, the most important thing is to kind of increase the rigor in our terminology. So instead of saying benign or aggressive, we might say less or more active, early versus late onset. Be very systematic in characterizing prognostic factors so we can do a good job. And in observational data set, if we start to capture in this modern era why we're choosing specific disease-modifying therapies and why we're stopping them, we perhaps can do a better job modeling and accounting for those therapies to take out some of that residual confounding. So I'm just highlighting our clinical trials, Treat MS, which is the one I run with Scott Newsom, and Deliver MS, run by Dan Ontaneda and Nikos Evangelou, and these are looking at how the disease-modifying therapies affect disability over time. And thank you very much. Happy to take questions.
Thank you, Professor Ellen Mowry. Very interesting lecture. I think there will be questions. There are a few questions we can entertain.
Hello, Ellen. This is Peter Hartung. I greatly enjoyed your talk, very thoughtful, outlining some of the, shall I say, limitations or deficits of the literature. And I couldn't agree more that we need to be more comprehensive in assessment to pick up this kind of subclinical activity or progression and coming to a better terminology. Have you seen, like I have, patients that were stable for 10 years, 15 years, you would call them benign according to some of the older nomenclature, and then all of a sudden had a drop and a significant increase in EDSS, so one still can never be sure.
100%. Yeah, I agree. There are some individuals that have that experience. have seen a few people post-COVID who randomly got a lot worse after they had a COVID infection more recently. So I think there is an interesting opportunity to study people who seem to kind of fall off a cliff. And then, I have a pretty large program studying risk-borne wearables, actually, to see if there are subtle changes occurring in individuals prior to disability worsening. And we're finding some pretty interesting changes in activity patterns that predate disability worsening in the wearables. So don't have time to review that all today, but definitely welcome to check out our papers.
Thank you.
Thanks.
Thank you,
Nice to see
Professor
you.
Ilan Henry. On behalf of Slick Trims, we give a big thank you for giving this wonderful lecture. Thank you once again.
Now, it's my great pleasure to introduce the final speaker for today, Professor Andrew J. Solomon, who is a professor of neurological sciences and the division chief of MS multiple sclerosis at the University of Vermont. In addition to his research, Professor Solomon is an experienced clinician who is actively treating individuals with MS and related neurological disorders. Now, let me invite Professor Solomon to commence his presentation. Over to you, sir.
All right. Hi, everybody. Thank you so much for having me. It's an honor to be here. I wish I could be there in person. I'm hoping another year that might be possible. So I'm going to talk about misdiagnosis of MS. I'm just going to get this set up here. And all right, here we go. Okay, so this is a picture from where I'm at right now in Vermont. This is my backyard, so quite different. These are my disclosures. I like to also add this disclosure because when I talk about misdiagnosis, it's not from the perspective of maternalism or that I could have done better necessarily. There are some misdiagnoses that are hard to avoid. And when I talk about this data, it's, the purpose is really to see how we all can do better. Diagnostic error is common in medicine and in for humanity, right? Starting off, I just want to point out that the misdiagnosis of multiple sclerosis is not a new problem. If you like Oliver Sacks, you can look at his autobiography. He's written about misdiagnosis in there. He talks about brain cutting sessions that he particularly enjoyed with young clinicians, and on one occasion they examined the brains of 5 patients who had been diagnosed as having MS during life, but the brain cuttings revealed that all of them had been misdiagnosed. On the right here, we have a paper from the 1980s by Bob Herndon, and he wrote a review on misdiagnosis of multiple sclerosis at that time. He has this quote here: "Nothing shuts off critical neurological thought processes faster than a diagnosis of multiple sclerosis," which I like. And this, kind of refers to this problem of anchoring bias, where we, once somebody has a diagnosis, sometimes we're reluctant to reassess it, whereas in MS, in particular, since we don't have a highly sensitive and specific biomarker, we should be continually reassessing diagnosis or vigilant for something unusual coming up in our patients. Like most data, some of the best data here on misdiagnosis is from Scandinavia, where they have national healthcare systems. And this study was in Denmark in the 80s, and this is really the best data we have. These are patients, 500 patients with diagnosed MS during life in the Danish MS registry, and these are postmortem exams, and 6% were found not to have MS. So they lived their entire life with this diagnosis. This was a while ago, so this was before MRI was really incorporated in our diagnostic criteria, and there were a lot of brain tumors in these patients. So it's hard to generalize this to contemporary practice. So I'm going to go over just really briefly that there are about 12 studies in the last 6 years or so that suggest that frequency of misdiagnosis is problematic, right? So, and I think something also important to emphasize here is these are not just studies in Europe or the United States. They're kind of all over the world. But primarily, these are studies where patients have been sent to tertiary care centers or MS subspecialty centers, not with a question about diagnosis. So they were transferring care. So it's not really a misdiagnosis if somebody is sent to a specialist with a question about MS, and that specialist decides they don't have MS, because that period is a time of diagnostic uncertainty to begin with. But these are patients who had a diagnosis of MS already and appeared at subspecialty centers, and you can see that these are varying. They're retrospective studies primarily that have various durations, 12 months in Los Angeles, and 2 centers, almost 20% have been misdiagnosed with MS. Patients were given the diagnosis previously, did not have MS. We have data from Portugal and SEMCAT in Spain, 7%. We have data from Iraq as well. This study in Peru found a very high rate of misdiagnosis, presumably due to lack of expertise in that region. In Argentina, Maria Inés Gaitan had looked at 8 years of data and found 16% had been misdiagnosed. And you can see similar numbers. Dr. Mowry's group found 12% in Baltimore. And we have a couple studies from Saudi Arabia recently. A couple other studies that are worth kind of highlighting here. There's a group in Rotterdam, and they looked at all their patients who've been diagnosed with primary progressive MS, all of them, and retrospectively, and found that 9% didn't have primary progressive MS. So a little bit different. Primarily, these other studies are focused on relapsing disease. And a group in Sweden had a registry, of that region in Uppsala, and they looked at everybody who was oligo clonal band negative in their CSF, and that was about 9% of their patients, which is what we expect in MS, right? But 12% of those on retrospective review didn't have MS. So hopefully I've convinced you that this is sort of a prevalent and global problem. There's a systemic review and meta-analysis here that was performed that looked at all of these studies, came up with this number of about 15% of patients out there who were seen in these centers carried a diagnosis of MS, were found to not have MS. I often get asked, well, what does this compare to other diseases? And this is a very large study in the United States that looked at over 200,000 patient visits, 80,000 unique patients in internal medicine, so primary care, and found diagnostic errors in 5%, 1 in 20, and about 12 million adults. This adds up, right? And about half of these errors were potentially harmful. So, I mean, what is an acceptable rate of misdiagnosis? I think most experts in that field, in this field, would say, 0, right? But some misdiagnoses are hard to avoid, but we'll get into this. But many of these disorders that are mistaken for MS are very prevalent. They're common disorders, and they're likely, preventable misdiagnoses. So let's talk about that a little bit. So what are the consequences of misdiagnosis of MS? Well, this is one study of 110 patients for MS centers that we did. And you can see the duration of misdiagnosis can be quite long. In this study, a third were misdiagnosed for 10 years or longer. A third were on disease-modifying therapy for 10 years or longer. 70% of them were on DMT. A quarter had been on a DMT with a known risk of PML. And about a third suffered unnecessary morbidity as a result of their misdiagnosis, often in the form of side effects from DMT or risks of DMT. But there was one patient with aquaporin 4 NMO who received MS treatment and died in this study. And we know that some of these treatments are ineffective for NMO. They didn't die in the study, but retrospectively they were found to have died. And if they had been on the proper treatment, maybe that would have been avoided. So it can be quite devastating. Patients don't receive the right treatment for their diagnoses when they're misdiagnosed, and sometimes for a decade or longer. DMT is quite costly, probably there as well. So there's just like tremendous costs, here in the United States, $100,000 a year maybe. So these patients, are on this for 10 years or longer, and they don't have MS. Even more concerning, some of these patients who have been misdiagnosed wind up in clinical trials for MS therapies. At 4% in this first study here, one patient, but it came at 13% in this next study, 3% in this other study. And I just want to highlight on the right the first case of PML on natalizumab. In a patient was treated with natalizumab and interferon as part of the clinical trial for natalizumab. This first fatality associated with PML was published in the New England Journal, and on autopsy, that patient didn't have findings consistent with MS, and raised some concern that that patient died in a clinical trial for an MS therapy and didn't have MS. Quite devastating. What are the diagnoses that are most frequent, most frequently mistaken for MS? So perhaps surprisingly, they're very common syndromes or diagnoses. And this was from this study, again, of 110 patients from 4 centers. Migraine, fibromyalgia, non-specific, non-localizing neurologic symptoms, not really a particular diagnosis, but in these patients we see with an abnormal MRI, white spots on an MRI, and they've got vague symptoms, functional neurologic disorder, as we just heard about earlier today, and a Mohs spectrum disorder. And this was before MOGAD was really described, this particular study. I'm going to go through these quickly, but I've mentioned about 12 studies, and they've all found something similar. This study, migraine, NMO, some systemic rheumatologic disease with CNS manifestations. This was a study in SEMCAT, again, and non-specific symptoms, functional neurologic disorder, migraine, cerebral vascular disease, not these esoteric diagnoses that can mimic MS. Very common disorders are mistaken for MS. Similar here in Argentina, you see peripheral nervous disease, you see all sorts of cerebral vascular disease, common syndromes, headache. This disorder, this was Dr. Mowry's group, again, small vessel ischemic disease, migraine, a lot of common disorders were mistaken for MS. So what's interesting, or what's important to highlight here, is the disorders that seem to be frequently mistaken for MS or misdiagnosed as MS are the disorders that are also frequently referred for MS evaluation. So this was a study in Kuwait and Lebanon, I believe, that looked at all the referrals to their center for possible MS. 26%, or about a quarter, didn't have MS. And here you see what they had. These patients were not misdiagnosed, but you can see this, the same list, essentially, of disorders that primarily are misdiagnosed as MS. We have a more rigorous study here from Italy. This was a multi-center study, over almost 700 patients, got a standardized workup, and about a quarter, again, didn't have MS. These are patients all referred for MS evaluation, and 2/3 or 71% of the diagnoses were kind of a similar list to what I gave you earlier. There were patients with nonspecific neurologic symptoms associated with MRIs that may be atypical MS, but had abnormalities. That was about a third of these patients. Migraine, again, with MRI lesions, systemic inflammatory disease. So some of these could be more rare, and aquaportin for NMO and MOGAD. Going back here first, what's important to highlight here is this suggests that if the disorders that are most frequently referred for MS evaluation are also the ones that are most frequently misdiagnosed, it suggests a problem with the diagnostic process, right? More generally, and these are disorders that we should be differentiating from MS. Proportionally, though, it may be that rare disorders are mistaken for MS more frequently. So not every patient with migraine is being misdiagnosed as MS, right? There's so much migraine. But because so much migraine is referred for MS evaluation, we're seeing a lot of misdiagnoses. So what I want to kind of emphasize on this slide is that less prevalent disorders like MOGAD and aquaportin 4 NMO proportionally are very frequently misdiagnosed as MS, at least in some preliminary data we have. This was a survey on top, and 55% of these patients with MOGAD were misdiagnosed, and a third originally were misdiagnosed with MS. Similarly here, aquaportin 4, primarily NMO-SD in Latin America, 12% were initially misdiagnosed, and 2/3 were misdiagnosed with MS. So when these disorders do present, probably very frequently they're misdiagnosed with MS because there's clinically, overlap, clinical phenotypes and imaging. But because the large number of patients with these other disorders are frequently referred for MS evaluation in our clinics, they seem like the most frequently misdiagnosed disorders. So what's happening? So in this particular study, apologies, it looks a little blurry, the scan. We surveyed or asked these MS specialists, there were 22 at 4 centers, what were some of the causes in retrospect of misdiagnosis. And these were the top answers. I mean, they pre-selected from they were selected from a list, but number 1 was inappropriate application of the diagnostic criteria in patients with syndromes that were atypical for MS, right? So the criteria require a typical clinical syndrome up until that time. Also, inappropriate application of historical episodes of neurologic dysfunction without objective evidence of a lesion. So these patients they had a symptom, but they didn't really have a lesion on exam or MRI that explained that symptom. But nevertheless, it was considered an attack of, or a relapse consistent with MS. And that led to misdiagnosis and a HAB. And then erroneous determination of juxtacortical or periventricular lesion location. So this idea of dissemination space is predicated on us knowing what those terms mean. And those patients didn't actually have juxtacortical or periventricular lesions who had been misdiagnosed. They have to touch the ventricles or touch the cortex. That's sort of the recipe that was validated, but there's a misunderstanding of those terms. So I've talked about all this misdiagnosis data. I want to highlight its limitations for a second. So in many of these cases, misdiagnosis of MS was made by a provider that was not the one who assessed the misdiagnosis ultimately. So, it's a retrospective review of these cases or these patients. So it limits how well we can understand what caused the misdiagnosis, right? Because we weren't there, and we may not, in many cases, have adequate documentation to understand what happened. There's something called hindsight bias, and the passage of time, it may be more clear that a misdiagnosis happened, as patients carry that misdiagnosis over years. So not totally clear that all these misdiagnoses were avoidable. And how generalizable this data is, especially to community practice, is unknown. These are from tertiary care centers that provide MS subspecialty care, so there's certainly referral bias. But we do have a lot of countries represented, a lot of regions, suggesting that this is a quite prevalent problem. So because of these limitations, and because we assumed that what's happening was that the application, comprehension and application of the core elements of the McDonald criteria were not being applied appropriately or were misunderstood, we did a couple surveys of clinicians, primarily in the United States, to see if that was the problem, right? Because this was all retrospective data. So this is about almost 400 clinicians over 2 studies, neurology residents in training, MS specialist neurologists, and then non-MS specialists, but neurologists who routinely diagnose MS. And we found problems. So first, let's talk about this idea of what's typical. So there's this concept in diagnostic criteria for MS that you can only use them in patients who have clinically typical syndromes or MRI findings. And this has been around for a long time. I just highlight here in the 27 criteria all the places where where it comes up. This is the 2024 criteria. I believe it's in there 48 times, this concept of typical lesions or typical clinical presentations. So the criteria are designed only for patients with those types of presentations or lesions, but there may be a misunderstanding about what those are. It's difficult to present a case here in detail, but we had a patient with migratory brief bilateral symptoms, kind of atypical for MS, right? The comorbidities that explain these white matter lesions on MRI. They had a normal spinal cord, no CSF data, and their MRI fulfilled dissemination space. They had periventricular and juxtacortical lesions. Only 64% of neurology residents recognized that this presentation was not typical of MS, while 95% of MS specialists did, and only around a half of non-specialists recognized this. We had a number of other cases like this, and of course, it's a survey. It's hard to know how well this translates to practice, where we presented typical and atypical presentations, and our providers or clinicians had trouble answering this. We also had a list of like red flag or atypical syndromes that would not be typical for MS. And a decent number of clinicians identified these as typical. Bilateral optic neuritis or severe unilateral optic neuritis with poor visual recovery is quite atypical in MS, but 47% of these neurologists who routinely diagnose MS thought that was a typical presentation. Complete gaze palsy, also not typical, or complete transverse myelopathy, but over a third thought this would be adequate to use for the diagnostic criteria for MS. And that's a problem, right? We have to rule out other diagnoses before we use the criteria. We gave a couple cases also focused on this concept of objective evidence. So, this idea that you have to confirm either on exam or with imaging that there's a lesion in the CNS. So we had somebody with a clear optic neuritis, but they had these vague lower extremity symptoms. They said I had some numbness or tingling in the past in my leg for a few days. We had somebody with myelitis, classic myelitis for MS, and they said, oh, 5 years ago I had some blurry vision. Many of the clinicians responding to the survey thought that was enough to qualify for a previous attack of MS. And you can see the numbers here. 88% of neurology residents, 65% of MS specialists, 86% of non-specialists. In both of these cases, very high numbers thought just this sort of vague history was enough. Whereas the diagnostic criteria, permits this for calling something in the past an attack. It strongly suggests that we corroborate these symptoms with something. So either an exam finding, so if somebody has lower extremity sensory symptoms, maybe a sensory level or at least unilateral hyperreflexia to suggest a lesion, or they have blurry vision like in APD, or finding, in either case, finding a lesion on MRI can prevent misdiagnosis, because there are monophasic causes of optic neuritis and myelitis that are not MS, and these patients might have had, a history of migraine that caused blurry vision or sciatica or something else. I'm just going to acknowledge that finding the subjective evidence of an attack is not always easy. This kind of references the first talk that we saw in this session a little bit. This is in Germany. They looked at about 200 patients with an acute relapse of MS who got an MRI before they got steroids, and they wanted to see if they could validate these relapses on MRI. And in 43%, they couldn't find a lesion to explain the relapse. It can be challenging sometimes. So I'll just mention that. But also, many of these patients may not have had a relapse. They may have had a pseudo relapse or reemergence of older symptoms. In this particular paper, they argue that many of these patients may have functional neurologic symptoms to account for this. But finding that objective evidence to confirm a relapse is very important. There was a nice paper a long time ago by Omar Khan and Aaron Boster that looked at about 150 patients who were evaluated with symptoms suggestive of MS without objective evidence of a lesion. And they followed them, surprisingly. And 109 returned over 4 years, and none of them fulfilled diagnostic criteria for MS because there was no evidence in MRI or on exam that there was a lesion to explain their symptoms, right? So this is like critically important aspect of our criteria. So we talked about these concepts of typical syndromes and objective evidence of a lesion, but MRI is equally important for our criteria. And I have this slide here. In 2001, the McDonald criteria incorporated imaging, and Charlie Poser, who was the author of the prior criteria, was very unhappy about this and published a lot of articles about how we're going to lose our clinical exam, and that we need to be face-to-face with the patient and the family. There's no substitute for clinical experience. Many of us still feel this way, but MRI has become very important for the diagnosis of MS. And Dr. Poser said, well, are we going to get to the point where the neurologist will no longer need to see the patient? Will MRI be the face of MS? And he published this kind of disturbing picture where he cut out an MRI and put it on someone's face. But this is, in some ways, with the new diagnostic criteria where we're at. Lack of recognition of what's typical on MRI is also a common cause, if it appears, of misdiagnosis. So here's the group from SEMCAT again. All of their MRI findings were nonspecific and not typical for MS. We need to know what these MRI findings in MS look like. There were many radiographic red flags in this study in LA of patients who've been misdiagnosed. We did this survey again of neurologists, and we said, which lesions are periventricular, which are juxtacortical, and we gave them 9 images. And only 4 out of 222 neurologists who routinely diagnose MS correctly identified all the juxtacortical and periventricular lesions, which is really concerning. So this suggests that a lack of knowledge for the foundational elements of our diagnostic criteria is probably driving a lot of this misdiagnosis. These lesions have to touch the ventricle, they have to touch the cortex, like in this picture. This is how the criteria have been tested and validated. You can't use a lesion that's just near the ventricle or near the cortex. We also tested just the definitions. And as you can see, people didn't do so well on this either. In addition to the imaging, very few neurology residents knew how to touch the cortex. Even MS specialists in this study, half thought that it was something just near the cortex or near the ventricle. Similarly, only 14% of these other neurologists got these definitions. It's pretty concerning, right? So this is particularly important, these knowledge for these dissemination space regions. These are the two, as we move into the 2024 criteria, you can see on the left, there's a pathway where we need to know if a patient has an attack or onset with progression typical of MS, and this is the pathway to diagnosis in the 2024 criteria on the left. But in the new criteria, we have patients who have, who have incidental imaging findings who can be asymptomatic or have symptoms that are nonspecific and can now be diagnosed with MS primarily based on their MRI findings. So we need to really know what these CNS anatomical regions are and what MRI lesions in MS look like. I'm just going to throw these two studies up. I'm not going to get into them, but essentially, I did these surveys in clinicians in the United States. Christine Lebrun-Fernet and her group did a study in France in 364 participants. There was also a trainee in Germany who did a similar study recently. And basically what they found was that there was a lot of trouble applying the McDonald criteria in theoretical cases, and a lot of misunderstanding of the key elements of the McDonald criteria, just including what's typical for MS and MRI dissemination space. So how might this all unfold for a misdiagnosis? So as an example, somebody presents with migraine, and it's not recognized that the syndrome is atypical, right? Because maybe whoever's seeing this patient is not as familiar with this caveat or important critical element, rather, of the criteria. So there's a syndrome where somebody's got, I don't know, some visual symptoms or numbness or tingling, but it's, maybe migratory, maybe it's lasted only a half hour, and it just doesn't localize well to the central nervous system, perhaps. And then they have nonspecific abnormalities on the left. And if you liberalize what periventricular and juxtacortical mean, you can see in this study, using older MS imaging criteria, many of these patients with migraine could meet dissemination in space. So if you have an atypical presentation, nonspecific brain MRI, and the clinician seeing the patient really is not rigorous about how they're applying the criteria and who they're applying the criteria, there's a risk of misdiagnosis. And certainly, as I mentioned, there's lack of objective evidence of a CNS lesion in many of these patients with migraine responsible for their syndrome, right? And if you get imaging, there's not much to find. So what's, kind of where we're headed here throughout all of these slides is is that the McDonald criteria do not discriminate MS from other disorders. You do, right? So patients with syndromes or clinical presentations and MRI that are quite classic for MS are required by the criteria first, before you can kind of look at whether they meet dissemination space or time, or have any, or you assess any of these findings from other paraclinical testing. So really need to know what's typical, and you need to exclude alternative diagnoses. And this has been in our criteria since Schumacher's proposed criteria in the 1960s. And this hasn't changed. So when you look at the diagnostic pathways here on the right and the left, this big red box, all of that is about excluding other diagnoses and making sure that the presentation, either clinically or radiologically or both, is typical for MS before we even apply the other aspects of the criteria. And so, kind of finishing up, just to hammer this home, let's say we have a 23-year-old who presents with visual impairment and a prior history of lower extremity sensory changes, and exam is consistent with optic neuritis. You find exam suggestive of myelitis as well, acute myelitis, and you've got an optic nerve lesion. You've got T2 lesions that are periventricular, and you've got a thoracic T2 lesion, and you've got oligoclonal band. So even by 2017 criteria and earlier criteria, you might say, well, maybe they have MS, right? They have 2 attacks. They have dissemination in space. They have dissemination in time by enhancing lesions or CSF. But if I told you their vision was 2400, they had severe optic disc edema on exam, they've got optic nerve sheath enhancement on MRI and a long anterior segment optic nerve involvement. Their thoracic spine showed a lesion from T8 to the conus. and their periventricular lesion completely disappears on an imaging, like an MRI a month later. Like all of this raises a lot of red flags for something else, right? So even though superficially, above, this patient might meet the diagnostic criteria for MS, we really need to pay attention to the clinical and radiographic findings. And in this patient, you might get MOG testing, and MOGAD might be a better explanation here. So again, the criteria doesn't discriminate this presentation from MS. You do, right? You need to know that these things are atypical for MS. I would just highlight that we have this paper that was an international effort by 55 authors that comprehensively details red flags suggesting disorders other than MS. Now, this could be pretty daunting. And so instead, if you look in this paper, as well as this paper in Brain, if you're just familiar with MRI, clinical and MRI findings typical for MS, and you could recognize when something doesn't fit and it's atypical, you don't even need to know what it is, but at least you pause before making a diagnosis, and that can avoid misdiagnosis. So we have these tables that just focus on optic neuritis, like what's typical for MS clinically, MRI, other findings, what might be atypical. You don't need to know all these disorders that you may never see, but at least if you know what's typical, you're much less likely to make a misdiagnosis. Similarly, this paper here on the right has sort of red flags for imaging that would not suggest MS, and green flags that would be typical of MS. So this is really the foundational starting point. Lastly, some people always ask me, can I just get a bunch of labs to rule out other disorders? And that's quite frequently done when we're evaluating patients for MS. I would argue that laboratory testing really needs to be guided by the clinical and MRI findings. And this was a nice small study. It's imperfect, but this was a single center study in an MS center where they had 150 patients who referred for MS evaluation. They had over 800 blood tests in those patients. Half of them were diagnosed with MS, half were diagnosed with something else. Only 5% had tests that were positive, and those tests resulted in lots of additional testing, 117 additional tests, 10 radiographs, 2 biopsies. So the take-home point here is these tests didn't impact diagnosis at all in any of these patients, and the serum tests were frequently ordered, but very infrequently abnormal to begin with, like testing all these antibodies, like rheumatologic antibodies without any kind of clinical findings suggestive of rheumatologic disease. They were infrequently abnormal, and then they had no impact on diagnosis. And then in some patients, you probably delayed the diagnosis by doing this broad testing, and there was unnecessary additional testing with morbidity and cost, right? Lastly, we talked about that implementation is not occurring in our diagnostic criteria with high accuracy around the world. This study was in 107 countries, and you can see here in the top left section here that we asked these countries through country coordinators, what criteria is used in your country for diagnosis of MS 2 years after publication of the McDonald criteria. Majority are using the 2017 criteria 2 years later, but many are still using older criteria that are less sensitive. And 20% are in 20%, the McDonald criteria that was contemporary and facilitated earliest diagnosis was not being used most commonly. And the primary reason was lack of awareness or training. I mean, there's certainly other barriers to implementing MS diagnostic criteria, but that's why I'm here is to highlight that we really need to know how to use this criteria in order to avoid misdiagnoses. So lastly, I'm just highlighting that we really don't know why the criteria are not accurately implemented in a global fashion. We just have a handful of papers, and we really need to do better after we publish diagnostic criteria to understand how they're being implemented, if people hear about them, if they know how to use them correctly. It seems like there are some problems, but we really don't have very rigorous data to suggest that. So wrapping up, sorry I went over a little bit. So hopefully I convinced you that misdiagnosis of MS is a frequent and prevalent problem. It seems like misunderstanding and misapplication of the diagnostic criteria and the core concepts of the criteria likely contribute to misdiagnosis. So if providers or clinicians really understood how to use the criteria in a rigorous way, we could avoid a lot of misdiagnosis in these common syndromes that are misdiagnosed. So this foundational knowledge for what's typical for MS and what's typical for clinical and radiological presentations in particular is essential for using our updated McDonald criteria in 2024 to avoid misdiagnosis. We don't really still know, like how our criteria are being implemented globally, and that kind of data could really help us design interventions to prevent misdiagnosis. We're not really there yet. And I didn't talk about some of these biomarkers that are now incorporated in the MS diagnostic criteria, central vein sign and paramagnetic rim lesions. These can really help us in the future avoid misdiagnosis because they're very high specificity for MS. So there's certainly some challenges in implementation in a global fashion. All right, I'm gonna end there. Thank you so much for joining me for this tour of MS misdiagnosis.
Thank you very much, Professor Solomons, for that very interesting and comprehensive talk. Now, in the interest of time, I think we can allow only one question.
Hi, Andy. It's Owen Flanagan here. How are you?
Hey.
I had a quick question. I was just wondering, I've kind of brought this up before, but of the cases that are misdiagnosed with MS, have they looked at what proportion have a full evaluation of MRIs of the spine and CSF? And then is it that when they're negative, they still get misdiagnosed? Or is it that they're not doing those and then they don't realize that they're kind of red flags if they're both normal? Because it's rare that CSF would be normal and spinal cord imaging would be completely normal. So has that been looked at, or?
I think that's a great question. Yeah, I think, so I often tell trainees that, the differential diagnosis for abnormal brain MRI is like here. But even, if you have short segment, multiple cord lesions, non-enhancing, it really narrows it to MS significantly. This cord imaging, and cord findings can be very, very specific for MS. And CSF certainly adds something. So I do always worry when I see a patient with MS who has neither bands nor abnormal cord. And honestly, I still worry if they have bands and an abnormal MRI but no cord lesions, because it's so specific and quite common. I don't think anybody's looked at this systematically in any of these studies on like what was performed and what the patients had. I could say anecdotally, based on a lot of cases of misdiagnosis that were, some of which were in these studies and some weren't, that I've seen or heard about, many clinicians are proceeding to diagnose MS in patients with normal cord and normal CSF. And they have done the testing, but nevertheless, they feel this perhaps pressure that they have to diagnose early. They don't have a better explanation for the brain MRI, and this patient in front of them has symptoms, and they presume it's MS. And often in those cases, the MRI itself is also quite atypical for MS and looks like small vessel disease or migraine. But I think that there's a lot of pressure to diagnose early because it does improve outcomes. And in many cases where there's uncertainty like this, we really need to take a step back. And some of these new tools, so in these cases, Owen, I think this is a great place for central vein or paramagnetic rim lesions. If you have a patient who has no cord lesions in particular, seeing central veins in many of their lesions or rims can be very reassuring for MS.
Or maybe like if artificial intelligence or something triggered something in the MRI report, this is, even if it was a central vein sign, this is, if it wasn't seeing it, it would say like, this is a big red flag for MS or something, then maybe that would help. Yeah.
Yeah, I mean, I think for central vein in particular, if there were, if there were multiple lesions, if you had a brain full of lesions and like none of them had central vein, I think that has high negative predictive value and can help. I mean, the problem is with like a trigger like that is often the brain MRI and the cord MRI are not being done at the same time, and CSF is done separately, so it's hard to figure out how to implement a trigger like that. But yeah, I think that's a really important point, very pragmatic, that if your patient doesn't have cord lesions or positive CSF in particular, high risk of misdiagnosis and pause.
Once again, I would like to thank Professor Solomon on behalf of Select Team's organizing committee for that very interesting talk. And let us show our appreciation in the usual manner. Thank you very much, sir.
Thank you for having me. Take care, everybody.